So welcome everyone. This is a session on working with people with bipolar in mental health services, and it's designed really very much as an introduction and or refresher. So we're covering a lot of ground here, so it's kind of breadth rather than depth, but hopefully there'll be something in it for everyone. So we'd like to start with some introductions. So first of all, my name's Kim Wright. I'm Professor of Clinical Psychology at the University of Exeter, and I co-lead the NHS-funded AccEPT service, which I'll say a bit more about in a moment. Adam, would you like to introduce yourself?
So hello, I'm Devon Mental. I work at the RISE clinic in Exeter with DPT, which is a sort of, I'll say a bit more about that in a bit as well, but a sort of medical version of Kim's clinic. I also work with the Tiverton CMHT. I'm the psychiatrist for that, and I've seen a couple of colleagues on the course already who I work alongside, so nice to see you there.
Great, thank you. And Pete?
Hi there, I'm Peter Burks, and I have a bipolar diagnosis, and I'm going to give an account of how it's affected my life over the last sort of 30 plus years, and then I'm going to talk a little bit later about Bipolar UK and the Torbay Bipolar Support Group, of which I help to lead.
Okay, thank you. So I'm going to say a little bit about the AccEPT service. It's useful maybe for people to know about. So we're an NHS-funded psychological therapies research clinic. We're hosted by the University of Exeter, but we are, like any other NHS service, we serve the local community. We're not specific to staff and students of the University of Exeter. We're here for the general public. We're an independent small provider commissioned by the ICB. And we aim to develop, test and make accessible effective psychological treatments and models of care for depression and other related conditions. And we sit in the gap between primary and secondary care. And we're one of a number of sites nationally in the depression theme of something called the Mental Health Mission, which is a nationally funded program to try to increase uptake of people into research that will benefit people with one of a number of conditions, and one of those is depression that isn't responding to treatment. So within the AccEPT service, we've got 3 treatment streams. One is hard to treat depression, another is bipolar disorder, and another is resilience and recovery, which is transdiagnostic. And in each stream, we typically include psychological treatment as part of research studies. So those might be small case series where we just see a small number of people, or they might be feasibility trials, which are small randomized controlled trials, and occasionally a larger definitive randomized controlled trial. We also, within each stream, aim to deliver kind of standard psychological therapy for that condition, so NICE recommended therapies, and that's often delivered by, for example, clinical psychologists in training, or members of our department who are clinically qualified and work for us pro bono to keep up their clinical practice. So hand over to Adam.
Thanks, Kim. So if you sort of imagine the same sort of framework Kim's just described, sitting with a sort of medical model and using medications as the main intervention, we are a clinic that basically is again part of the same national network of clinics that's aimed at sort of increasing uptake of getting people to access new and novel treatments for hard to treat depression and bipolar. We're quite new. We've started seeing patients at the end of December, but essentially the offer is patients and GPs who might struggle to get patients seen by secondary mental health services. So we're sort of also aiming at the sort of gap in between services. But essentially we allow patients to have a very sort of thorough review with a psychiatrist. That would be me or a colleague at the moment, hoping to recruit sort of more people to do the assessments. And we have a good sort of 2-hour chunk of time to sort of really get to the bottom of what's worked in the past, what hasn't worked, and we're able to offer some advice to patients and primary care in a kind of stepwise framework of if this works, if this doesn't work, try this, and so on. So there's a bit more sort of forward guidance than you might get otherwise. As Kim said, we're research focused as well. So the aim is that that people might be interested in getting involved in research trials that are running in DBT at the moment, and that's again with our clinic it's mainly based on medication interventions. So either treatments that are used in other disorders but might have a role in mood disorders, and that's unipolar and bipolar depression, or completely novel treatments. And actually, there's a fair amount of stuff that's going on in mood disorders that that's quite new at the moment, and that may have a sort of good role in treating mood disorders that we're hoping to get involved with. So there's no obligation to take a part in any research, but we're hoping that in coming to the clinic, people might be interested in getting involved in the future.
Okay, thanks, Adam. So I'd now like to ask you to introduce yourselves anonymously, if that makes sense. So I've got a Menti survey, which is an online survey. So if you've got a device that allows you to take part, it could be your laptop, it could be your phone. You can either go to www.menti.com and then enter this code, or you can scan this QR code with your phone if you're using your phone. So you won't see any questions at first because I have to launch the survey, which I'll do sort of in front of you, and we'll see it come up live. But I'll just give you a moment to try and get onto the Menti site. And then once the Menti results of the survey come up, there will be the code in the corner, so you can still join if you haven't managed yet. Okay, so I'm going to stop sharing. I'm going to share the Menti screen, but don't worry, the code is at the top, so you will still be able to join. So hopefully you can now see a slide with a question. So on your device, you should be able to answer that. So it's asking you about your professional identity. The code's up there at www.menti.com. Interesting to see. We've got a whole variety of professions here, which is great. Lots of therapists, but also we've got nurses, support workers, recovery practitioners, wellbeing practitioners, service managers. Great, super. Okay, so next one. Have you ever worked clinically in any capacity with someone with bipolar? I didn't know what the right word was. By clinically, I mean in your roles. If you're a support worker, nurse, therapist, have you ever worked with someone, a patient with bipolar? So looking like, yes, people have experience of working with people with bipolar, which is great. You'll notice that I'm using the word bipolar rather than bipolar disorder when I'm talking about bipolar. I think there's a movement in recent years to drop the disorder when talking about bipolar. At the same time, you'll find in the literature it's referred to as bipolar disorder, so that term's sometimes used on the slides as well. Okay, so the next question, have you delivered therapy for someone with bipolar? So this is only going to apply to a few of you who deliver this or have delivered this as part of your role. So a few people have, many people haven't. And I guess that should work quite well today. The section we've got on psychological therapy is quite introductory, but hopefully there's something there for those who have worked in terms of psychological therapy with someone with bipolar. And then what are your growing edges when it comes to working with people with bipolar? So by growing edges, that is a euphemistic way of saying what are the areas you feel you need to develop? What are your kind of questions? So someone said treatment, and treatment options. Yeah, we'll be covering that today for sure. Yeah, appropriate therapeutic intervention knowledge. We'll be doing that in breadth rather than depth, but we're hoping to have another session where we go into more detail about in depth in terms of psychological therapy. Similarly for adapting low intensity protocols. Efficacy, yeah, we'll be covering that. Yeah, knowing where to signpost for quickest, most up-to-date therapy. Great. Yeah, so hopefully most of these will cover at least a bit. And then I think what we might do is look to get some feedback at the end of this session to inform the content of a later, more in-depth session on some of these topics. So the aims of today, we're going to talk about diagnostic criteria for and the phenomenology and lived experience of bipolar. We're going to look at pharmacological treatment recommendations, and we're going to cover some psychological treatment recommendations and main components. And Pete's going to tell us about a local bipolar UK support group as well. So without further ado, I would like to hand over to Pete, who's going to say a little bit about his personal experience.
Thanks, Kim. Okay, so this is really my bipolar journey. As I said, I'm Peter. I'm 63 years old, married to Helen, with 3 grown-up kids and 2 lovely grandchildren. In 1990, when I was 28, my bipolar journey began. After losing my father to suicide, moving house, starting a new job, and becoming a father for the first time, I had a long, deep depressive episode which ended my career as a building surveyor. During the next 10 years or so, I managed to pick up the pieces, getting back to work again, having 2 more children, and living a fairly normal life once again, with only minor ups and downs. However, during the first half of 2000, I had another long bout of depression, which then led on to a full-blown manic episode. I was sectioned and spent 3 weeks as a patient on the Haytor ward at Torbay Hospital. This is when I was given my bipolar 1 diagnosis and the start of lithium as a mood stabilizer medication. After my discharge from hospital, I was offered several different therapies, including practical artwork, pottery, music, along with some group CBT talking therapies. Fortunately, with amazing support from my family, friends, and work colleagues, coupled with effective medication and therapeutic interventions, I've managed to come to terms with my bipolar and have learned to manage it rather than fight or deny my diagnosis. I think acceptance is key when trying to live and move on with bipolar. There is a strong genetic link with bipolar and mental illness in my family. I've lost my father and older sister to suicide, and recently my 32-year-old son was diagnosed with bipolar. I think this has made me realise my own vulnerability, but also increased my determination to look after myself, live the best life possible, and support research into bipolar. I have been happy to take part in various bipolar research studies, including genetic blood tests, True Colours mood tracking programme, and Beating Bipolar at Cardiff University. Also, the effects of caffeine and exercise with bipolar mood, and the benefits of blue spaces and green spaces with mood at Exeter University. I've also been involved with Bipolar UK for the last 12 years, and I helped to lead the Torbay Bipolar Group. This has proved to be a great benefit to me, and I'll be talking about Bipolar UK and my local group later on this morning. This has been a whistle-stop account of my last 35 years, and I'm happy to delve more deeply into any aspects of it later on. So please feel free to ask any specific questions during our Q&A session at the end of this workshop.
Okay, thank you so much, Pete. And I'm sure that Pete's account may resonate with lots of people here in terms of some of the experience that Pete's had. I can see that people are posting in the chat their thanks, Pete, for sharing your experience. And Pete refers to a number of things, including how he first received his diagnosis of bipolar, and also a number of different things that have been helpful across his life. And I think some of those we'll talk about today in terms of the sort of formal formally recommended therapies and pharmacological interventions, and others we won't, but can be equally important. For example, the kind of friends, family, and involvement in activities and community organisations as well. So I just want to say what we're going to present today is part of what can help people, not all of what can be helpful and supportive. So going to move on now to think about diagnosis. So I'm going to say a little bit about this. I'm going to be going off DSM-5 just because it's kind of more nailed down in terms of all the criteria, which it's very similar to ICD, which is used, I guess, in clinical practice more in the UK. But where there are differences, it's mainly around ICD allowing for more clinical flexibility and judgment. So, for example, not mandating a specific number of additional symptoms as DSM does. So, if what we cover here very much does apply, though, to ICD. So, DSM talks about two main subtypes of bipolar 1 and bipolar 2. So for a diagnosis of bipolar 1 in DSM, you have to have had at least one manic episode, and we'll talk about the criteria for that in a moment. So it's a bit of a strange one in a way, because the old name for bipolar was manic depression, but to have a diagnosis of bipolar 1, you don't actually need to have experienced an episode of depression. And in fact, it's estimated that around 20 to 30% of people don't experience depression, they only experience the manic side. Bipolar 2, however, you do have to have experienced at least one major depressive episode and at least one hypomanic episode, which I'll talk about the definition of in a moment, and no full manic episodes, or else it would be bipolar 1. So in terms of what mania is in DSM, it's described as a distinct period of abnormally and persistently elevated, expansive or irritable mood, and abnormally and persistently increased goal-directed activity or energy that lasts at least a week. Now, I've put that bit about energy and activation in red because that was a change from DSM-4, and it recognises that there's a kind of increasing move towards thinking of bipolar disorder less as a disturbance of mood primarily, and more as a disturbance of activation and engagement. And I think that's recognised in that goal-directed activity and energy. So it's not just about feeling super positive, it's also about being activated as well. And you'll note the irritable mood part, people don't need to have that elevated mood component at all. They can have irritability alone as the mood change. It says a week, but in DSM, they say it can be shorter if the person needs to be admitted to hospital. I guess recognising that once people are admitted, they may be given treatment that reduces the length of the episode, but yet it still may be a manic episode. And then during that period of mood and energy disturbance, you would need to have at least 3 of a list of additional symptoms. So the first one is inflated self-esteem or grandiosity. And this is defined as not just being more confident than normal. Sometimes people say when they finish a period of unipolar depression, my confidence has come back, I'm feeling much better about myself. It's more than that. It's having ideas about yourself or your abilities that when you look back later on, you might think, that was really not merited. And this can shade into unusual and unshared beliefs about yourself and what you're able to do. For example, being able to control the power supply by the force of your mind for the city or something like that. Is decreased need for sleep. So the example they give in DSM is feeling rested after only 3 hours of sleep. And remember, this is for at least a week typically. But people often will say, and I'm sure, Pete, you've heard people say this, I didn't sleep for nights on end. And I didn't need to sleep. I was full of energy. The third and the fourth one have got a subjective and an objective element. So subjectively, the person might feel a pressure to keep talking. And objectively, people might say the person's more talkative than normal. Similarly, for the fourth one, subjectively, the person might feel that their thoughts are racing. Objectively, somebody else might say the person's jumping from topic to topic, it seems. It's difficult to follow their train of thought. And then linked, I suppose, distractibility. So finding that your attention is drawn to things that are not relevant. People often might report, well, I started one thing and then something else happened and I moved on to that, and then something else got my attention and it was difficult to finish a task. And then the sixth one is about increased activity. So either in a goal-directed fashion, so like working a lot harder for a lot longer, or socializing a lot more, or some people describe just being full of energy that they feel they need to burn off. So like going for a sort of 4-hour run in the middle of the night, or spending hours and hours in the gym, or just pacing around a lot. And the final one is often the one that causes the most difficulty. So getting involved in activities that have got high potential for painful consequences. So spending large amounts of money, having sexual encounters that you wouldn't normally have, making rash business investments. People sometimes talk about getting into fights, provoking fights just for the fun of it. Maybe engage, sort of buying a ticket somewhere without really planning a trip and ending up on the other side of the world without any of the usual preparations that you might need to make. And if you have at least 3 of these symptoms plus the one at the top about mood and energy, for mania it has to cause problems. So marked impairment either at home, with relationships, with money, with your physical health, at work, or result in being admitted to hospital, or there are what are called psychotic symptoms present, so people having unshared ideas or unshared experiences, like seeing or hearing things that other people can't hear or see. And it has to not be due to the effects of a substance or another medical condition, because of course there are some conditions or substances that can mimic some of the symptoms of mania. And I won't go into that here, but I'm sure you might be aware of a number of different causes of some of these symptoms that aren't to do with a manic episode. So then hypomania. So hypomania is actually the same symptom set in DSM. So it's you draw from the same symptom set, same criteria. You've got to have at least 3 of the additional symptoms, but 2 big differences. The first is in DSM it can be shorter, so 4 days rather than at least a week. That doesn't mean it is shorter. People can be hypomanic for weeks or months. It just means it can be shorter. Probably the most important difference is that hypomania doesn't cause problems, doesn't result in the person going to hospital, and the person doesn't have any psychotic experiences as part of that episode. Instead, DSM describes it as representing an unequivocal change in functioning and observable by others. So typically people might say things like, well, colours were brighter, I had more energy, I was more confident, I was more productive, people said I was more cheerful and more sociable, but it didn't actually get in the way of anything or cause any problems. And as we'll come on to shortly in terms of sort of some facts about bipolar, there is typically a delay to diagnosis. I think that's been estimated fairly stably at around 9 years in the UK on average until people from first episode to getting a bipolar diagnosis. And I think when we look particularly at the experience of hypomania here, we can understand why people don't tend to present looking for help with hypomania, because by definition it doesn't cause a problem, and so they're more likely to be seeking help around depression. So just a word about mixed features. So in DSM, this has sort of replaced the idea of mixed episode. This is where you have at least 3 symptoms from the opposite pole present nearly every day throughout the episode. So if you're depressed, you also have some manic symptoms, or vice versa. And then I'd just like to mention in DSM there are another 2 kind of points on the bipolar spectrum. One is called other specified bipolar, which is a sort of catch-all where clearly the person has a bipolar pattern to their mood, but they don't quite fit any of the categories in terms of what they've experienced. And then cyclothymic disorder is where people have brief spells of high and low that aren't sufficient to meet clinical criteria, and rare occasions with no symptoms. So there's a felt sense by the person of mood going up and down without much break from that over a long period. It has to be, for cyclothymic disorder, it has to be at least 2 years. Often it's much longer, and it does seem to be increase your chance that you will develop bipolar 1 or 2 later on. So a little bit about epidemiology and impact. In terms of lifetime prevalence of bipolar 1 and 2, each is around about 1% of the population, and that's fairly stable globally. There's a peak in onset in young adulthood, but people can onset across the lifespan, really. It is more difficult, of course, to diagnose in children and young adolescents. And the majority of people do experience more than one episode, although there are people who will say, I've only had one manic episode, nothing else. And I've mentioned that a subgroup of people don't experience depression at all and just mania. There's a high rate of comorbidity with other psychiatric conditions. That's been estimated at 50%. And sadly, there's the rate of completed suicide in bipolar is very high. It has been claimed to be the highest of any psychiatric condition. And also, people with bipolar do seem to be at elevated risk of dying early from natural causes. But I do always want to say when I talk about this that these are population statistics. These are averages. It doesn't mean if you have bipolar that this will happen to you. Just really important to make that point here. The UK spends quite a bit of money in connection with bipolar, estimated at nearly 6.5 billion at prices as they were in 2018, 2019. So that's including healthcare, but also other costs to the economy around employment and so on. So it makes sense to invest in improving what we can do to support people with bipolar. So I'm going to hand over to Adam now.
Thank you. So we thought it would be good to just mention a few alternative diagnoses that essentially can look like bipolar and often coexist with bipolar, which makes it very complicated. I suppose I mentioned that it's often the case that people, particularly with bipolar 2, tend to present a bit later for help, and often their diagnosis has been characterized as other things, but also people who have had a diagnosis of bipolar may in fact have a diagnosis of something else. So there's quite a difficulty in psychiatry overall, because there's a lot, each disorder represents a bit of a spectrum of symptoms and experiences, some crossover with other diagnoses in terms of the symptomology. So there's a lot of grey area essentially, but I thought that there are some key distinguishing characteristics that might be useful to go through, which gives you a sense of what's going on. And I've just realised, I've used the ICD diagnosis, so we're not quite comparing apples with apples here, but there's so much crossover between DSM and ICD that I think we can sort of take that as read, basically. So why is it important? I think it is for a variety of reasons. One is from the medical sort of side. It gives rise to knowing what treatments work and what there's an evidence base for. So essentially, if you try to treat the wrong thing, you're not going to get very far. So, for example, organic disorders like thyroid dysfunction or substance use can present as different types of mood disorder, and if you're not addressing those elements and you try to treat it as bipolar, then you won't get very far, and you'll probably end up causing side effects and difficulties for people. So it's important to sort of identify what's going on at base. So yeah, and in particular, psychiatric disorders, there's a much greater role for medication than in other psychiatric diagnoses. So, for example, in personality disorder, which I'll mention in a bit, there is much less of an evidence base for the sort of dramatic, changeable impact of medications, whereas in bipolar or schizoaffective conditions, there is much more of a role for medication. I think for people themselves, having diagnosis that they can attach a framework for their own thinking, for other people's thinking, their family, their friends, and so on. It seems to be very important. Plays an important role in people's lives, and they're forward thinking about how things might play out for them and what they can do to have an accurate diagnosis. A bit of a caveat to it in that medical diagnoses can be, or at least psychiatric diagnoses can be sort of easy to get, and they are sort of based on a description of symptoms, and it sometimes can give rise to a sort of quite reductive sort of approach to people's experience, in that I have this checklist of symptoms, I have this disorder, and that's it. And so I think, the formulation behind what's going on for people is also incredibly important to hold in mind, as well as someone's diagnosis, because that will affect elements of their life in a much more sophisticated way than just referring to a list of symptoms. So I think we need to hold both things in mind when we're thinking about bipolar and other psychiatric diagnoses. There's also potential harm from diagnoses as well. This is more of a sort of broad philosophical principle, I think, but it's not necessarily a universally beneficial thing to receive or give a diagnosis, and that can be because you are getting a diagnosis where the symptoms don't quite match or aren't at the level at which might be accurate, because then that gives rise to treatment, which has all sorts of side effects and so on. And there's also a danger of identity being attached to a diagnosis as the guiding principle for people's lives. And I guess that gives rise to the thought about formulation and what else might be appropriate guiding principles for how they live their lives in the context of having mood disorders. So I just thought about to talk about schizoaffective disorder, because that probably is the one that most maps on to a diagnosis of bipolar, in that it's essentially a mix of schizophrenic-like or symptoms, schizophrenia-like symptoms, and bipolar, that are both at the same time, and mood symptoms occur sort of independently of those schizophrenia-like symptoms. When I mention schizophrenia, I'm talking broadly about people hearing voices, having experiences that other people don't share. So they might sort of have very strong beliefs, often quite worrying and paranoid beliefs, about that they might be being followed or targeted, and that people are joining lots of things up together that other people aren't making, and other people aren't making those links. That those often can sit alongside the mood disorder elements of mania, or depression as well. And so we can have a sort of, it can be either pole, as it were. Essentially, when it comes to schizoaffective disorder, the treatment from a medical perspective is very similar to the bipolar. We tend to use more antipsychotics as a mainstay of treatment in schizoaffective disorder. So you'll often find people with diagnoses of both, or that sort of evolve throughout their lives, and they're sort of returned as schizoaffective disorder or bipolar, as they sort of go throughout their lives, and might sort of display slightly different symptoms at different times. So in some ways, there's a bit of an academic sort of distinction between these two disorders, but there is a bit of a difference in outcomes. So people with bipolar tend to have a bit fewer symptoms sort of in the in-between times when they're well. They have much more sort of clear time where they're not affected by symptoms, and there's some evidence that people with schizoaffective disorder have sort of worse cognitive outcomes, so difficulties with long-term cognitive impact in later life than people with bipolar disorder. But in terms of the treatment, it's roughly similar in terms of what we use medically, at least. So one very common bit of sort of diagnostic overshadowing, as in people who sort of disorders that can look similar to one another, is emotionally unstable personality disorder. And that can look very similar to bipolar 2, mainly because there's a lot of emotional ups and downs within the context of EUPD. I personally I don't really like the diagnosis of EUPD in that I think it's an appropriate diagnosis to give in some situations, but it's an unfortunately and unfairly pejorative one in mental health settings through no fault of patients at all, but mainly through the fault of the healthcare system overall. But it's an important one to distinguish when you're, I guess, sort of seeking mental health, in contact with mental health services, partially because of that reason, and also because the role of medication in that system, in this diagnosis, is not as evidence based. But I guess the key distinguishing factor is the temporality of the mood fluctuations within EPD. So there's much more rapid shifts of mood that occur often with a sort of a stimulus that is characteristic or that's associated with the diagnosis itself. So within the diagnosis of EPD, there's a lot of hypervigilance or looking out for sort of constant fear of rejection and abandonment that can often give rise to the marked sort of shift in mood as a sort of trigger for that. And the mood shift is much more rapid than in bipolar. But often that's somewhat difficult to determine from the history, because people will not necessarily will often present and say my mood is always X, Y, or Z, when actually if you pick it apart a bit more, there's much more sort of rapid shifts up and down. The other thing is that the other elements of EUPD, so the impulsivity, interpersonal instability, fear of abandonment, and so on, are all consistent in the background. Whereas in bipolar disorder, that tends to be associated more with the mood changes itself, which sort of happen much more on a fluctuating basis in sort of weeks or more, or I suppose 4 days or more in the context of bipolar 2. But yeah, there's a lot of crossover in terms of people's reporting, and people often will have a diagnosis of bipolar 2 when actually they may have some elements of EPD and vice versa. So complex PTSD is another quite similar sort of pattern to EPD. Again, could quite look like bipolar because of sort of quite rapid shifts in emotional state. So I guess for complex PTSD, it's referring to PTSD that's essentially had an early life or repeated element, which makes it A, much more difficult to treat, but also B, happen in the context, present alongside symptoms of emotional dysregulations, problems with relationships, and sort of a negative perception of yourself, that all of which are again sort of unshakable and persistent throughout people's experience. In addition to the core symptoms of PTSD, which is hypervigilance, so being always on edge with about the particular thing that's caused the trauma, re-experiencing things and being avoidant of those. That avoidance leads to difficulties with relationships, and this emotional sort of up and down, which can look quite similar to bipolar. And again, role of medication in smoothing out that emotional dysregulation within complex PTSD is much less evidence-based than it is within bipolar. So that's sort of another reason to distinguish between the two. So ADHD also very commonly and I'd say there are many people who I've met that do have both, and so it's often very difficult to distinguish between the two. But again, there are different treatments for them, and also the treatment of ADHD within bipolar medically can be quite complicated as well, because you're essentially well, if you're treating with a stimulant, which can be, and then you may put someone's bipolar at risk, as in their propensity to manic symptoms at risk. So it's quite important to sort of pick this apart and discuss sort of risks and benefits of treatment with people. But I guess overall, the temporality of the pattern of symptoms is really important, in that the core symptoms of ADHD are consistent. There's a little bit of worsening and sort of variability within people's life, but they are present before the age of 12, which is really important, because it's considered a developmental condition, and then are fairly persistent throughout their life. Although there is some idea that essentially the more demand you put on people throughout their lives, the more you can kind of unmask symptoms by increasing the sort of load the demand on them. So, for example, going to school or university, or having your first job or child, those sort of additional stresses of life can sort of make symptoms worse at those times. But I guess in the room, ADHD can look quite similar to bipolar in that often people present with quite pressured speech, seem quite impulsive, seem quite upbeat at times, or actually quite low at other times. And so it's sort of mimicked bipolar, and you'll often see people with ADHD who've been treated for bipolar quite unsuccessfully, and then sort of coming to clinic later and finding that actually treatment for ADHD works a lot better for them. So substance misuse again often occurs within the context of people with bipolar, who might use substances for lots of different reasons. But I guess the important thing is that substances themselves can cause really profound mood disturbance. So, and that's both whilst taking them themselves, the direct impact, but also if you're intermittently using some substances, it can have a significant impact on your mood, to the extent that your presentation can look like you either have depression or probably more like hypomania or mania in the context of some substances. So I would say in terms of stimulants, I'd say have the strongest sort of impact on people's mood, to the extent that they may look like they are experiencing a manic episode. So amphetamines, MDMA, and cocaine often can cause sort of brief episodes of psychosis whilst they are being taken, and also can again in the room present like people are experiencing a manic episode, due to things like pressure of speech or sort of elatedness and so on. And then actually when they stop using them within a couple of days, whilst the substance washes out of their system, they're completely changed. And then don't necessarily go on to sort of develop another manic episode unless they start to use stimulants again. So essentially the treatment there is to stop using the substance. So important to distinguish there, because again, if you treat those presentations with mood stabilizing or antipsychotic medication, you will be doing potential harm from the side effect without the real need for those. So alcohol, persistent use of alcohol, even a few pints a day, or a few units a day of what the recommended intake limits can cause a depressive sort of type of symptom, a depressive type of experience and symptoms. And so again, the intervention there is to help people reduce and stop their intake. Dissociatives like ketamine, again, there's some link between as well, because ketamine is sort of a new treatment for depression, but there is some evidence that long-term use of street ketamine, at least, is associated with depression. Although lots of people who use it say that they use it for their depression and difficulties with sort of trauma-based illnesses as well. Hallucinogens like LSD and psilocybin, again, big sort of growing evidence base for their utility for treatment within unipolar depression, at least. But can either, there's some evidence that they can either kickstart a psychotic or a manic episode. And again, whilst in the context of intoxication, there's a people have all sorts of experiences that can be read as a psychiatric illness that washes out when they stop. And another sort of footnote for steroids. So people who I guess use anabolic steroids to bulk up might, when they stop, they get a very depressive sort of symptomology. And in the context of using them, it can increase things like aggression and energy levels and so on. And then again, that can be read as manic or hypomanic episodes, and corticosteroids as well. So if you ever needed steroid treatment, I'm not talking about steroids for eczema. I'm talking about sort of oral steroids at high doses that can have mood promoting effect as well. So some people very rarely sort of will use them in the background and have mood effects as well. So yeah, just word for organic disorders. So again, these are just a note to say that there are a variety of organic disorders that we should exclude before we start treatment with medications. I think sometimes we don't do a particularly good job of that in psychiatry, and we should remember to do the checklist of that, particularly for things like hypothyroidism or hypothyroidism, which can cause is probably the most common sort of background medical thing to mimic mood changes. But there are all sorts of other. This is just a sort of basic list of organic conditions that can cause changes in mood, energy levels, inhibition, and so on, that might look like either hypomania or mania or depression that we should consider. So this is an extremely busy slide, which, for full disclosure, I used ChatGPT to develop. I've checked through and I think it's accurate. So I'm glad to see that I've still got a role of something in terms of psychiatrists being able to check detail for things. But anyway, I think we're circulating the slides afterwards. So it's a bit of a reference point in terms of a ready reckoner for what should be present in which condition. And how we might distinguish between all of them. So just wanted to spend a bit of time on medication, given that it is something that people with bipolar will very often be taking at different stages in their lives. So we thought we'd go over essentially the sort of established nice guidelines, the evidence-based ones, and then what happens in reality, a bit more, and some of the risks and benefits of each approach. So I don't want to get too nerdy about it, but I thought we'd have a good look at some of the sort of theory about efficacy, just on the very broad of principles about it, rather than going into the intracellular mechanisms, which I'm not sure if I understand very well anyway. Talk a little bit about the difference between first episode and relapses, and treatment of the acute phases versus remission phases as well, and then have a really sort of probably spend a bit more time on the risks versus benefits, talking about the, I guess, side effect of lots of medications that people might take, is that might be something that you as clinicians will speak with patients about, because they can be quite prominent. So the NICE guidelines, these are they for the treatment of bipolar in its various different forms. The NICE guidelines are based on, it's a sort of consensus statement based on a review of the evidence, so using things like meta-analyses and Cochrane reviews and so on, which are all sort of broad consensus statements, often in themselves, about the evidence base for treatment in particular medical conditions. And they give a recommendations for clinicians working with people with conditions in the NHS and beyond. They're relatively similar to those in other countries, which is probably just gives rise is a result of the fact that the evidence base is similar internationally, although each country will sort of use a slightly different interpretation on them, and often there's the influencing factors that make them recommend particular treatments or not. But there's a lot of crossover between, I guess, developed countries, countries with developed economies, in terms of their approaches. So the mainstay of treatment is, so these are the fluoxetine plus olanzapine and quetiapine for bipolar depression. Just wondering, it's probably not worth me just reading out all those things, but that's there for a reference point if you want. So why does medication work overall? I will fess up that I guess we don't understand what the underpinnings of human consciousness and experience very well on a molecular level. So we can't really make huge claims about why medication should work and hence influence those experiences. But broadly, it's about sort of dialing down excitatory neurotransmitters, so things that sort of increase neuronal activity in the brain in a manic state, and turning up the volume when people are in a depressive state. And within that there's a certain amount of sort of stabilization of those things that we hope to achieve when people are free from their symptoms, which we may not be able to achieve in everybody. So the other thing to say about medical treatments is that you'll often have people sort of give a shorthand about correcting serotonin deficiencies in depression, or sort of we just need to sort of correct an imbalance, as it were. And it's not quite as straightforward as that. We can only make statements, or broad statements, about the role of particular neurotransmitters, because we know it's an extremely complicated sort of cascade of neurotransmitters that occur, and we're only really approaching one element of that, and we don't really have a particularly good overview yet of what if we do one thing, what happens to the rest of it, because it can have downstream and upstream sort of effects on things as well. So talk about mood stabilizers first. I'd say in terms of mania, I'll mention this again, you'll tend to see antipsychotics used as a mainstay of treatment more than mood stabilizers, although technically lithium is meant to be the gold standard for treatment of mania in remission, so maintenance treatment. But basically the overview is that they are meant to be, as I said, sort of dampening down the excitatory neurotransmitters and boosting the inhibitory ones. And so lithium, again, we're not 100% sure how it all works, but we know that it has an effect on dopamine, so it will reduce effective dopamine. Glutamate, which again is a neurotransmitter that's excitatory, and GABA is inhibitory. So it's for example, GABA is how benzodiazepines and alcohol is sort of thought to partly thought to work. So sort of again a sort of slightly depressive sort of impact on what's going on in terms of the level of activity in the nervous system, central nervous system, that is, rather than peripheral, although there are peripheral effects as well. There's a bit of crossover with epilepsy here as well, because glutamate is one of the neurotransmitters that is implicated in people having seizures. So too much glutamate essentially broadly gives rise to seizures, and so you'll see a lot of these medications being as a crossover between epilepsy and bipolar. So lamotrigine and valproate in particular are used, and you may also see some people who are still on things like carbamazepine or topiramate, and those are more used in epilepsy. But again, it's about that sort of happening down of excitatory neurotransmitters. So this is basically lithium, lamotrigine, and valproate, which tend to be the key mood stabilizers used in bipolar. So psychotics are also used. So often you'll see people put on antipsychotics in the acute phases of mania, or sometimes hypomania too. That's somewhat pragmatic in that it's quite, because in starting lithium, and I'll talk about this in a bit, you have to get baseline blood tests, you have to monitor them, monitor people with blood tests, and monitor the levels of lithium, and that would be quite difficult to get people to sign up to in a manic state. So there's a sort of pragmatic use of antipsychotics in the acute phases. There's also got a good evidence base as well, but you'll fairly rarely see people started on lithium in a manic episode. They might switch to it or have it added in. But basically, the main mechanism for antipsychotics is that they work on dopamine, the old school typical antipsychotics, which were sort of I guess developed in the 50s to sort of 70s type of time frame, just used to work very strongly on dopamine, the D2 agonist, and they had more side effects, more sort of physical side effect than the newer versions of antipsychotics that we use now, which have their own side effects but slightly different ones. So the antipsychotics tend to have more sort of physical side effects like stiffness or tremor, or people sort of feeling and looking quite sort of masked in terms of their expressions. So it's sort of more of a visible sort of cluster of side effects and symptoms that people might show when they're on those antipsychotics. The newer psychotics have a much broader impact, although they're still working via dopamine, but also histamine, that's the H1, adrenaline, and noradrenaline, that's the alpha signs, and the 5-HT is serotonin, various different receptors there. And as a result, they don't have fewer sort of physical side effects, but have much more in the way of long-term side effects, like I guess promoting, putting people at increased risk of things like diabetes, high blood pressure, stroke, and so on. So we need to be careful about monitoring people for those things when they start on newer antipsychotics. I've sort of included the future ones mainly because that was what was on the image that I poked from a slide. There's not a huge amount of promise in the forthcoming antipsychotics that are used, that are coming out in probably the next sort of few years or so. I hope to prove wrong on that one, but I think we probably can leave those ones to the side for now. So antidepressants, I thought I'd include these because you will often see people with bipolar taking antidepressants. It's essentially harder to treat in the context of bipolar than other depression, or often is, but we often try anyway, and patients often want to give it a go because they feel they want for anything. But the antidepressants overall work on a variety of different mechanisms, and sort of trying to influence some single neurotransmitter targets and some multiple. The main ones you will see used are SSRIs, which essentially increase the levels of serotonin in neurotransmission by blocking the reuptake of that and destruction of it in one of the cells. So you'll mainly see people on things like citalopram, escitalopram, and so on. Venlafaxine and duloxetine are SNRIs, and they work a bit like SSRIs at low doses. Then as you get higher up in the dose, they kick in with something called a noradrenergic effect, so increase the level of adrenaline that's used that's being sort of fired off between neurons, and that is potentially has impacts on things like sort of motivation and energy, although it's part of a broader sort of system that seems to just have an evidence base in treating depression and anxiety as well. Metazapine is one you'll also see people on. Again, works by a slightly different mechanism, and metazapine is often used when sleep is an issue because it's quite sedating. It works via histamine and other receptors that cause you to feel more sleepy, and the same as trazodone as well. That's probably less used than others, but again has an impact on sleep. And I guess that sleep is really important within bipolar, so you might see people on those. There are lots of other older antidepressant medications that are used, but I can't I can't do them all here. So you'll see all sorts of different antidepressants used. So just a word about sort of first episode versus relapse. Maybe again we sort of talked about this in the questions about just the layout of services and how they're delivered provides for some sort of quirks in people's ability to access treatment or not. This is one of them. So essentially, if you have a manic episode with psychotic symptoms, you are sort of eligible for this pathway for treatment with as a first episode of psychosis. So I work with lots of people in that sort of framework, and it essentially gives you a bit more of a intensive treatment mainly for psychosis rather than bipolar, but you're sort of committed this 3-year sort of program of treatment via STEP services and Devon Mental EI services elsewhere, and there's some evidence that there's an impact on the prevention of the progression of further psychotic episodes, but also just better outcomes overall in terms of people being in work, having being able to take next steps in their life and so on. If there's not psychotic, if there's no psychosis presence, then you don't get that intensive support. People might be sorry, and I think I've neglected to say about the STEP program is that it's meant to be diagnostically blind, so you don't sort of give a diagnosis of bipolar within the first episode. You just term it as a psychotic episode that may never happen again. I guess if you don't have that, if you're not part of that sort of diagnostically blind approach, people might be more willing to term your symptoms as a lifelong illness, although that stands slightly at odds with what Kim said earlier on about people not getting a diagnosis for a while. But I think that's probably more for people with type 2 bipolar, where psychosis isn't even sort of an issue, and lots of different diagnoses that we've talked about before. Kim, do you want to go to the next slide? So in terms of treating acute mania, I've said a bit about this before, but I guess you tend to use psychotics as the first line, and I'd say they work, and I've seen people transform in terms of their presentation within a few days of starting an antipsychotic, which is great news for lots of reasons, but I guess there's also lots of considerations in terms of side effects and so on to think about later. As I said, we tend not to use lithium in the treatment of acute mania, although you can, and often it's added in. We tend not to add in sodium valproate as much anymore, and I'll talk about this in a bit in terms of the side effects, because there's a particular consideration within, well, actually, I was going to say both women of childbearing age, but also now men, in terms of impacting their fertility, and there's some evidence that it can impact on the sort of genetic material within sperm and so on as well. So there's a potential for it to have an impact via both routes, whilst you're on treatment on conception. So we tend to only use it when it's absolutely necessary or outside of women of childbearing age. You can use clozapine, which is a particular antipsychotic which is used in treatment-resistant schizophrenia, which is really efficacious for psychotic symptoms. It's used much less widely in bipolar, but can be used off license in type 1 bipolar when people have just repeated manic episodes and whilst they're on treatment. It again comes with all sorts of side effects and risks and needs ongoing monitoring, quite intensive monitoring for the first 6 months or so that you're on it, and then monthly monitoring going on. So it's quite a thing for people to be signed up to. And it might be some surprise, maybe not, I don't know. We still use ECT in, I guess, affective disorder overall. It's really reserved for life-threatening depression, so where people have stopped eating and drinking and a risk of dying as a result of that in the context of depression. But it can technically be used for prolonged manic episodes, again, where there's sort of threat to life. I have never seen it used in my career as a treatment for mania, although it's technically sort of licensed for that and can be used, so I include it here as a sort of footnote. So in terms of remissions, when maintenance treatment for mania, lithium is particularly the first line, and has a really good evidence base in terms of helping people stay well. And I'd be interested to hear your experience overall, having mentioned that you were prescribed lithium overall. It's got some potential sort of long-term side effects that again need monitoring for. It's a really good treatment for maintenance therapy. Lots of people end up just keeping on the antipsychotic that's got them well, and you then start to sort of think about the dose that's appropriate in staving off any future episodes, at the same time as minimizing side effects. I guess the advice is, and again, sort of using the early intervention framework, is that you should stay on treatment for at least a year after symptoms resolved in the first episode. That's again if psychosis was present, as it often is in manic episodes, with the psychosis being mood congruent, so sort of associated with an elated or irritable mood. After, if we're talking about relapses, after you've had your second episode, you're meant to have reviews every 6 months. The NICE guideline says to do that. But really, the evidence base is suggestive that the safest thing to do is to stay on treatment for as long as you can. That's not to say that everyone who stops medication will have another episode. We just know that as time goes on, if you're off treatment, then there is just an increasing risk overall that you will have another relapse. You already mentioned about sort of other stresses and so on that might kickstart a manic episode, or other factors that might sort of predispose you to having another episode. Life throws these up, so it's not impossible to have several episodes, then come off treatment, and then never have an episode again. But you're at a much more increased risk of doing so if you want to come off treatment completely. Depression and bipolar, yeah. So I have found personally that it's quite difficult to treat, especially in type 1 bipolar, in the phase after a manic episode. Often people describe quite prolonged low periods after, especially a full-blown manic episode, and we're not quite sure whether that's sort of part of a natural course of people's condition, whether it's almost inevitable, it's sort of part of some rebalancing of neurochemistry somehow. but also it can be somewhat associated with the treatment itself. So if we're using antipsychotics, there's some subjective experience of people describing, I guess, little motivation, sort of not getting pleasure from things and so on, and antipsychotics do affect that. So they block dopamine, which is associated with people finding meaning in things and motivation and so on. So, we may be causing some of the depression symptoms themselves, by treating things. It's really difficult to unpick what's going on. So it's all about sort of discussion about risks and benefits of treatment with people, because often removing the potentially causative medication can put people at really high risk of going back into another episode. So it's a really difficult situation for people to be in. So overall, the recommended treatment is olanzapine and fluoxetine. You'll often see people on different combinations of antipsychotic and antidepressant. Although you can just be on therapy because it's meant to have good sort of some antidepressant activity as well. So whilst people are on lithium, there's some role for lithium as a antidepressive treatment itself. It's often used in unipolar depression as alongside antidepressants when people have really hard to treat depression. So it does seem to have this this antidepressant effect. So it's important to get the right levels for that. And again, valproate's a bit of a footnote there because lots of people aren't on that anymore. So lamotrigine as a treatment itself, it does have a sort of moderate evidence base in the treatment of depression within the context of bipolar. It doesn't tend to protect against mania. So I tend to use it when patients want to more in type 2 bipolar, when the risks of becoming higher are slightly lower than in type 1. Some people don't want to have that risk at all, so want to try and stay on a mood stabilizer that protects against mania, like lithium or an antipsychotic as well. There's some risk of something called switching in antidepressant use. So if you just use antidepressants alone in bipolar depression, there is some evidence, although not very strong evidence, but that you can essentially cause a manic episode at some point. And some people will find that they have their first manic episode when they are treated with an antidepressant for that depression. And so there's some suggestion that you can kind of tip people into a manic state by using antidepressants alone. I think in reality the risk is pretty low on a population level, but with some individuals it does seem to have that impact. And that's mitigated by being on a mood stabilizer as well. So the olanzapine fluoxetine combination is basically shown to have no risk of switching people into a manic state. The other thing to say about, again, antidepressants in bipolar is that they're not as efficacious as antidepressants in unipolar depression overall. So there's a bit of a difference in terms of the treatment. And I think I said the other two things about sort of subjective numbing effect and so on. So we go on to the next slide, please. This was a bit of a sort of slightly messy but sort of overview slide of the role of different medications in different conditions. Again, I stole it from another online. I've adapted it slightly. So we tend not to use much Rosine. I deleted a couple of other things that were on it from episode, but this is the overall. And I think the ziprasidone, you'll not see many people on that, but those are the mainstay treatments, I'd say, of treatment in bipolar. I'd say you'll see few people on lurasidone as well, though it's some evidence base for treatment. It's an antipsychotic medication, but for treatment in both mania and depression as well. So side effects. Unfortunately, all of the treatments do come with potentially significant side effects, and Some people get none, and that is wonderful, because I think lots of psychiatric medications have a reputation, for good reason, for causing quite significant side effects. So I'm always really pleased when people come back to me and say, "Yeah, it's treated, my depression or my bipolar," and no, I'm feeling fine. I don't have any side effects at all. I'd say those probably a minority of cases for antipsychotics overall that people don't get any side effects at all. And some of those side effects might be somewhat indolent in terms of putting them at increased risk of things like diabetes and cardiovascular disease on a long-term basis. So they might not sort of experience them on a day-to-day level. But I'd say the ones that the medications we tend to use these days tend to have more longer-term effects. So the older antipsychotics, things like chlorpromazine and haloperidol, those are the ones. Well, actually, chlorpromazine was the first antipsychotic. Haloperidol was slightly later. They cause much more physical side effects, so things like stiffness and tremor and things called tardive dyskinesias, which is ED on that slide there. You'll see many fewer people, far fewer people on those antipsychotics as the others now. So the ones that you'll see these days tend to be things like clozapine, risperidone, olanzapine, and aripiprazole. We tend to try and use aripiprazole when psychosis and mania, if possible, first, because you'll see from the sort of pluses and minuses that it's got fewer side effects associated with it. It's sort of seen as a bit more of a light touch antipsychotic, but actually, in terms, if you look at the evidence base, it's pretty much as efficacious as on a population level again as all the others. But some people do seem to need a different antipsychotic. We don't know why. This is the same for all medications. There's probably some genetic predisposition to people being more responsive to one rather than the other, and that might be because they work it off more quickly, and they sort of essentially work it off more before it gets to relevant neurotransmitters. And some people just have a slightly different shaped neuroreceptor, which means that the effect isn't sort of as pronounced within the nervous system as other people. But yeah, so lots of different side effects in terms of antipsychotics. So lithium overall, again, really effective mood stabilizer. It needs monitoring because lithium levels themselves can be toxic if they build up too much. So you need to do sort of monitoring every time you change a dose, and need to watch out for adding in other medications that cause lithium to be more present in the bloodstream as well. So things like ibuprofen, which is really commonly people buy themselves. You need to be really careful to sort of counsel people not to use that as a sort of primary pain relief or anti-inflammatory. There's also some longer term effects that happen and need to be monitored. So we tend to monitor kidney function and thyroid function every 6 months when people on a stable dose. And I've said a significant proportion of those on long-term lithium therapy will develop kidney or thyroid dysfunction. It's a sort of notable minority of people. So for a start, most people, when you stop lithium, either kidney function or thyroid function will rebound and recover. But in some people, about sort of 1 to 2% of people overall, it causes irreversible damage. So it's again always thinking about the risks and benefits of these treatments. So lamotrigine. I'd say lamotrigine's one medication. There's lots of different side effects listed here. It's pretty well tolerated overall, and people tend to be. I've not had that many people who have said, "I can't tolerate this. Need to stop it." Main reason to stop it is that people develop a rash, and a very small subsection of those rashes can be something potentially fatal called Stephen-Johnson syndrome, or epidermal necrolysis, which is a very fast developing and potentially fatal skin condition. And again, it's a really tiny minority of people that might experience that, but you have drilled into you at med school that you must ask and tell people about, good reason, about the potential outcome, but often scare people off wanting to take the treatment, which can be quite, it's got a sort of moderate evidence base, not a brilliant evidence base, but it can be quite effective in treating bipolar depression. Should we go on to the next slide? So just a word about valproate. So it used to be a real mainstay of treatment in mania and bipolar, potentially for a bit too long, in that we have known about the potential impact of valproate in utero on fetuses for some time, and it's often said that the advice about this has come out a bit late, but you've got a really high risk essentially in pregnancy if you take valproate of genital malformations. So it tends to influence the development of the spinal cord and brain. So babies born with fetal valproate syndrome often have developmental delay or a host of other difficulties as well. So it's really sort of used as a kind of treatment of last resort for people who could conceivably start a family. And that's in men as well now, in that there's some evidence that it can influence the male fertility in that way. And it was a pretty good treatment for mania, although again with some subjective side effects as well, because of this sort of additional consideration. You'll see fewer and fewer people on valproate overall, and if you do want to continue doing it, then taking it, then you need all sorts of forms signed, which are too specialist nowadays. Just think about antidepressants. There's many different sort of classes of antidepressant. I've sort of listed a bunch here. I wasn't quite sure, again from the slide, I wasn't sure what an SM antidepressant was, but maybe ignore that line. And the DCAs and MIOIs are older antidepressants, so you'll see them used less. But again, they have a whole host of side effects, and I think all medications that we tend to use in psychiatry, people experience more various, not necessarily a higher frequency or incidence of side effects using antidepressants, but there's just so many different side effects that people seem to experience. Some of them are short-lived, so things like nauseousness and so on tend to sort of resolve as you get used to treatment, but there are some others like weight gain or sexual dysfunction, so difficulty getting an erection or loss of libido and so on, that people don't necessarily talk about, and you have to sort of ask them about it. And that can have a huge impact on people's lives. So again, thinking about whether people feel it's worth taking antidepressants or any other treatments, and weighing up those risks and benefits. Should we go next slide? Oh, and we're finished. Yeah.
Okay, thanks so much, Adam. I'm sure that there'll be some questions for Adam. In the interest of time, I'm going to suggest we save those till the Q&A at the end and move over to talk about psychological therapies. So I'm going to talk about this for a little bit, but we will have a break shortly, and then I'll talk again after the break. So just thinking first of all about the main recommended approaches in terms of psychological therapy. So here I'm talking about formal protocolized or manual-based psychological therapies. There are also a broad range of psychosocial interventions, I suppose, that you might see available for people in the mental health services. Here I'm focusing on the formal psychological therapies. So across the world, there seem to be at the moment 4 types of psychological therapy that tend to be recommended in countries where they have guidelines and so on for people with bipolar based on the evidence base. So the first one is psychoeducation. So that is usually delivered in a group form, and in fact there's evidence that it's more effective delivered in group form than in individual form. And that's about helping people to gain knowledge about bipolar, self-management strategies and so on. I'll say a little bit more about that in a moment. Cognitive behavioral therapy, usually delivered individually. That's what the evidence base for bipolar is around. And when it's trying to address mood states in bipolar, it's looking at patterns of thought and behavior that might contribute towards the onset of an episode or that might maintain an episode once it's started. And then interpersonal and social rhythm therapy, IPSRT. So this is based on something called interpersonal therapy, which is about, it's quite a behavioral approach actually to helping people kind of manage their social roles and have the kind of good interactions with others and manage relationships. And into that, the developers put in some elements about social rhythms, so rhythm and routine, because there's quite an extensive evidence base that there does seem to be for many people with bipolar, a role of circadian rhythm disruption in making people vulnerable to episodes, and potentially an important role of light in particular as a trigger that, or not a trigger, but they get called zeitgebers, something that helps set the circadian rhythm. And there's a lot of research going into circadian rhythms and bipolar at the moment. Hopefully we'll have more on this in the coming years. But circadian rhythm disrupting events, so events that disrupt your daily internal rhythm, seem to be particularly they seem to be particularly likely before the onset of an episode compared to times when people don't have episodes. And sleep disturbance as well, as Adam mentioned, seems to be quite a common both early warning sign and potentially trigger of episodes, in particular manic episodes. And then family focused therapy is it's not traditional family therapy exactly. It gets called like a family focused intervention. So it's got quite a kind of behavioral and problem solving element, but delivered within the family. So you're helping people in the family understand about bipolar, ways of managing bipolar together, looking at problem solving, and also look at communication training in the family. So across those four approaches, all four of those have got an evidence base for relapse reduction. And CBT, IPSRT, and focused family therapy have got a decent evidence base for reducing depressive symptoms, but group psychoeducation not so much so. So just to point towards this web page, which was launched a couple of days ago. So this is from the International Society for Bipolar Disorders. They have they're a group of clinicians, researchers, and some people with lived experience who are interested in kind of improving treatments for people with bipolar disorders. And they have a task force based around psychological interventions. And we've put together this web page, which is trying to be a one-stop shop for clinicians internationally who are just thinking, I can offer therapies, I want to offer therapies, I don't know what to offer people with bipolar. So this web page kind of goes through these four, like briefly outlines the four, and signposts or links people into the manuals that were underpinning the successful randomized controlled trials for each approach, and also some materials as well. So it's quite brief, but hopefully helpful. So the link is there if anyone's interested. So I'm going to start, because I think within bipolar, thinking about psychological therapy, the evidence-based approaches that we've got tend to address either, as I said, relapse prevention or acute depression. We have a lot less around acute mania, and that's for a number of reasons, including it can just feel really difficult for people to engage in a psychological approach, a formal psychological approach during a manic episode. Also, manic episodes are usually quite short-lived, so it can be quite difficult to kind of set up the therapy and get in there during that episode. So for that reason, it tends to be more around relapse prevention and acute depression. What I want to say here, though, is that I wouldn't make the assumption that everyone with a bipolar diagnosis who's wanting psychological therapy wants the therapy to target issues around their bipolar. So lots of people with a bipolar diagnosis might come to therapy looking for help around relationships or around anxiety disorders, PTSD, difficulties with eating, etc. So as I said, I think therapy is 95% the same, at least in my area, which is CBT. It's 95% the same as it would be for anybody else. But I'm going to focus on the 5% that's different here. So when we think about the relapse prevention work, there's this evidence for manualized therapies reducing relapse risk relative to control treatments. Now, the reason I say manualized therapies is that there aren't lots of trials of any one therapy approach. So meta-analyses often group them together. They do try to separate them where they can, and that's why we get these things, including in NICE, saying manualized treatments. So an odds ratio of 0.56 means they about half the risk of relapse, usually over the coming year. And then for CBT specifically, it's a similar odds ratio as well, so about halving the risk of relapse. Important to say that all of these approaches, the trials have tended to be whilst people are already taking medication. So the psychological therapy is on top of medication, not instead of medication. Some of the trials are usual care, but even in those, most people in those trials are taking medication. So we're not in a position of saying to people, well, you can choose between, in terms of the evidence base, this psychological therapy is as good as this mood stabilizer. The evidence base isn't there, and the trials are tricky to do because there would be lots of concerns about people withdrawing off medications to be on a trial like that. I think this is an area, though, that people are curious about. People who can't or don't want to take medication, how helpful can a psychological therapy be for me? And I think pragmatically, there's absolutely, I would say, yes, the trials are of people taking medication, but if somebody can't or doesn't want to take medication, I would still want to offer them a psychological therapy if they're interested. There's no reason to think it wouldn't be helpful. So what does NICE say about relapse prevention? They say offer family intervention to those in close contact with families. That practically, I don't see that happening very much in the NHS in this country. But otherwise, a structured intervention for bipolar with an evidence-based manual. So that's like CBT, IPSRT, obviously focused family intervention or group psychoeducation. And they give a list of things it should involve. I'll talk more about that in a moment. They say that these programs should be tailored to the person's needs based on assessment and psychological formulation. So, then thinking about the other aspect of bipolar that these trials tend to focus on, which is acute depression. So actually, very few trials actually look at treatment of acute bipolar depression. A lot of them, it's people either who are currently fairly well or the episode isn't defined. And what they're looking at is whether the therapy reduces what are often residual depressive symptoms. So it's quite difficult to say. Adam was saying that it can be really difficult to treat bipolar depression in terms of pharmacotherapy. The psychological therapy, we don't have many trials where we can say for sure the people who started that trial were in the midst of a major depressive episode. They were acutely depressed. But from the evidence that we do have, including just for depressive symptoms overall, it does look like CBT, interpersonal social rhythm therapy, and focused family intervention can be helpful. This review by Yilmaz et al., and then there was another version of this in 2025. Really, it looks, I would say the evidence base is probably the strongest for CBT. If you look at the number of trials and the consistency of the effect sizes over those trials for reducing depressive symptoms. But again, these trials tend to be adjunctive to medication, in addition to medication, not instead of. So what does NICE say? They recommend either a psychological intervention for bipolar depression with an evidence-based manual, or a high-intensity intervention for unipolar depression. And that's interesting. NICE note there aren't that many differences psychologically between bipolar and unipolar depression, so they make the pragmatic recommendation that you could use something that would be used in unipolar depression with an evidence base. But do keep an eye on symptoms whilst people are in treatment, and you should have some training in and experience of working with people with bipolar disorder. So I'm going to talk a little bit more about what's in these therapies. So it's been observed that across those 4 therapy types I described, they have so much overlap in terms of the content that's covered. And Miklovitz and colleagues carried out a network meta-analysis, which is where you synthesize all the evidence, all the trials, but you can do it by the components or the different parts of the therapies and try and work out which ones might be helpful. Anyway, key components that they pulled out as being involved in a lot of the therapies included psychoeducation, so information often with active skills practice, self-management, so particularly managing, noticing and responding to early warning signs of a relapse, self-monitoring of mood, symptoms, sleep, thoughts and behaviour, so keeping a track of things so you can help to maintain balance, maintaining daily rhythms and routines, communication training, so helping people think about how they can communicate with others, whether that's about bipolar or about any other matter, problem solving, behavioural activation, which I'll mention a little bit about in a moment, and cognitive restructuring, so looking at unhelpful thinking patterns and looking at other perspectives on situations. So I'm going to say a little bit about some of these common topics and then talk about CBT in particular, which is my area. So psychoeducation, in terms of a group, there are lots of quite a few protocols out there for group psychoeducation for bipolar, but whether group or individually delivered, or whether it's a component in a bigger therapy, topics tend to include what is bipolar, so what did it tend to commonly involve, and what do we know about what causes it, what are the treatment options, how routine sleep and lifestyle can play a role for some people, sort of advice and techniques around managing stress, work on spotting and responding to early warning signs of a relapse, and some element of involving family and friends, which I'll say a little bit more about later. So another thing I mentioned is self-monitoring. There are lots of options for this, particularly with new technology, in terms of both how you monitor and what you monitor. Quite commonly, people will monitor mood, but they might also monitor other things like particular kind of physical symptoms that they have, sleep, use of medication, and so on. So you can work with the person. What you typically do in therapy is work with them to decide what's going to be most useful to monitor and what's going to be manageable, not too much of a burden. It has been advised, though, to use mood monitoring thoughtfully. It might not be helpful for everyone at every time. And a good example of this is some people, for very good reasons, are very anxious about mood changes, and doing self-monitoring by definition kind of involves you putting attention onto your mood, energy, and so on. And for some people, that just exacerbates their anxiety, makes them more concerned. So in terms of kind of clinical recommendations, based not so much on the evidence base, because there isn't much direct testing of this, but just on kind of clinical advice in this paper, are that if you're going to do mood monitoring with someone, make sure the person definitely wants to do this, they can see the point, they're happy to do it, and that they have a plan for if they should notice a change in mood, because you don't want a situation where someone notices that mood is changing and they just feel really helpless because they don't know what they can do about it. So luckily, often in therapy, you'd be weaving that in right from the beginning so that people might know how to respond if their mood is changing. And here from the Bipolar UK website are a few different tools that are available, a diary, a tracker app, and a mood scale that people can use. So just to mention the mood scale, so Bipolar UK have got their own mood scale, which many people like, where mania and severe depression are there in red, and then you've got the kind of intermediate states in yellow and balanced mood in green, and there's numbers from 0 to 10. And people don't have to use this at all in Bipolar UK, but they put it out there, and often people will maybe say to their clinician, actually, I like the bipolar mood scale, I quite like to use that in my self-monitoring. Worth noting, Bipolar UK do have a new version of this mood scale, but I know there are different opinions about that, and that some people prefer the old ones. I've put both of them up, and Pete will say a little bit more about this later. So another thing I wanted to talk about in particular is sleep work, because as we said before, sleep disturbance is a symptom of depression and mania, but it can also be an early warning sign for some people, and it may well play a causal role in relapse for some people as well. So in psychological therapy, we often find ourselves working around sleep in some capacity or another. But I think it's really important when you're doing psychological therapy with anybody really, but particularly in bipolar, because sleep is so important, not to make assumptions about what that sleep work involves, because it could be different for each person depending on what their current sleep issues are and what they want to achieve. So there's this sense of, first of all, finding out with the person, what's your sleep pattern like? How does it relate to how you feel? You know, what do you want to get out of that? And in my experience, this doesn't come from anywhere. This is just in my experience. There are sort of three areas we tend to end up working on. So for some people, there's a problem with their ongoing sleep pattern. You know, they have to get up in the morning to be able to go to work in the future. That's what they're working towards, but their sleep pattern shifted round and they're not able to get up, or they're sleeping in the day. And that's where there are some strategies that you can draw upon in kind of sleep work around helping people to manage their sleep pattern. So that can be sleep hygiene advice, which, you know, things like darkness, quiet, and so on, use of devices and, you know, stimulation at night time to try and help people fall asleep quicker. But there are also more specialized sleep management programs. Now, I think you have to be quite careful in doing some of these with people with bipolar. So some of the sleep management programs out there for the general population involve things like sleep restriction. That could be tricky in someone with bipolar. So I think you have to tread carefully there, and you know, potentially if you can have access to specialist supervision, that's helpful too. Another thing that commonly people say is that they're very anxious about their sleep. So it's not necessarily always about the amount of sleep, it's about someone's relationship to their sleep. And that's where CBT for insomnia has a lot to say about how you can manage that, and looking at people's thoughts and testing those out with response to sleep, doing behavioral experiments and so on. And often, you know, in some cases, it's actually the sleep isn't a problem, it's the anxiety about sleep. Finally, some people their sleep is okay on an ongoing basis, but it goes off in advance of an episode. So there's something about both noticing when that sleep disruption is happening and on putting things in place to maintain a decent sleep pattern across time, if that does seem to be something that can get in the way. And this can be particularly tricky when you're working with people who, for example, do shift work or who are parents of young children. So yeah, you can, you know, kind of think quite carefully about how can I protect my sleep as much as possible within the lifestyle constrictions I've got. So I'm now going to talk a little bit about CBT for relapse prevention in bipolar and CBT for depression. So starting with CBT for relapse prevention, I'm drawing on what isn't really a really cognitive model, but is a more general diathesis stress model that's been used in one of the manuals underpinning trial of CBT for relapse prevention by Dominic Lamb and colleagues. So this is quite a simple model. It says that stressors come along like life events or having to be very driven in your behavior, maybe towards a work deadline or something. That interacts with a biological vulnerability, to lead to a prodromal stage, so an early stage of an episode where it could go either way and you might start to get some early warning signs. Then people cope one way or the other with those early warning signs, and the way that the person copes can influence, not always, but can influence whether it develops into an episode. The episode itself can create further stresses in life. And so the idea here is that in terms of intervention, and those stresses cause stigma, relationship problems, and so on. And the idea is that in terms of intervention, we might be looking at how people can manage their coping and also how people can manage this stress and stressful life events. So I'm just going to go through a fictionalized case vignette for somebody called Leanne. So this is sort of invented based on what people have said. So Leanne is a 32-year-old woman who lives with her mother. She works for an animal charity in the fundraising department. She reports having depression on and off since adolescence. On a few occasions following very stressful events, she has rapidly become overactive and disinhibited, resulting in her going into hospital once and being diagnosed with bipolar 1. Since then, she has taken lithium, which she finds takes the edge off the highs and lows but doesn't prevent them. Her upbringing was challenging in some ways. Her father was very controlling of her mother, and her older brother, and could be violent. He died when Leanne was 10. She now thinks he might have had bipolar disorder. Her mother was very anxious and spent a lot of time in bed. She drank alcohol to cope with social situations. Leanne did well at school, but had a rebellious phase in her teens and feels she is employed below her capabilities now, although she likes working in the charity sector and in connection with animals. Leanne's most recent relationship ended 18 months ago, and 6 months later, her ex-partner Mia died in a road traffic accident. Leanne described getting busy to distract herself, terrified the bereavement would drag her under. Her mood started to escalate, and she found herself wanting to go out lots in the evenings and hosting parties for strangers in her flat. She started missing work and got into financial difficulties because she gave money away and had money and items stolen from her. This lasted for a couple of weeks, after which her mood and energy crashed. Her landlord did not renew her rent contract because of her behaviour, and she moved into her mum's house. She felt tired and low and went off sick from work, spending lots of time in bed and avoiding friends. So, if we were going to apply that relapse prevention formulation for Leanne, we might think about the high episode first. So there was her ex's death. She threw herself into other things to distract herself. That's not necessarily a manic episode at all. That's her coping response to a bereavement, and quite understandable. But she has a biological vulnerability, let's say, towards being vulnerable to experiencing mania potentially, and the combination of those two things, she started to get some early warning signs, harder to get to sleep, increase in energy, and faster thoughts. In response to that, maybe she capitalized on that by on having more energy, by doing more, and she was following some of the thoughts she was having, and she ended up having a manic episode. Because of what happened during the manic episode, there was problems at work, stigma at work, and she was evicted from her flat. That then meant she was living with her mother, having money problems and work problems, so life events that are tricky. Again, interacting with the vulnerability. This time, the early signs were of low, so it's hard to get out of bed. She was ruminating, not wanting to see friends. To cope, she went off sick, turned down social offers, and stayed in bed. This turned into an episode of depression, caused further issues at work, friends stopped calling, and so on. So you can see how you can go through this cycle once for one episode, but it can then make it more likely that you trigger off that another cycle gets triggered off. So thinking about key techniques when people are thinking about relapse prevention, spotting and responding to these early warning signs. In therapy with an individual, typically what we do is talk through a well-remembered episode of mania or depression, because we do this process once for each if people want to do that. So what was the first thing you noticed before your mood started to change? You want to get really early on what happened next, and so on. And you're looking out for behaviors like spending money, for example, thoughts maybe like I can take on this big project when you wouldn't normally, certain feelings and emotions, changes in the body like a fluttering feeling in your tummy or a sense of heaviness in your limbs or whatever, urges, for example, an urge to travel to the other end of the country or whatever for no reason, and other people's reactions as well. Maybe people make comments they wouldn't normally make based on what they're seeing of you. And then you get those into a list of warning signs, an ordered list in time, check back against other episodes, and then in parallel, you then want to develop, or after that, develop a parallel list of how to cope in the early, middle, and late stages, and then making a plan for how you share this, how you keep it accessible, and how you'll be able to know when these signs are happening. No point making this plan if it's just going to go into a drawer. So an example for Leanne might be early signs, urge to go out in the evening, taking more than 30 minutes to get to sleep for 2 nights. And she decides, if I notice these signs, I'll stick to only 2 nights out a week. I'll take a sleeping tablet and I'll tell my mum. Middle signs, maybe if that hasn't worked, I'm staying out late in bars after my friends have gone, I'm inviting people back to my flat. If I'm able to, I'll contact the mental health team, I'll tell Adam, and I'll give mum my credit card. And then at the late stage, I would be using drugs. I'd be giving away more than £10 to people. If I can, I would ask for urgent support. And there's probably a parallel plan, maybe with mum, for example, of how mum can respond at these different stages. So another thing that can be really helpful in doing work around relapse prevention is looking at the pattern over a lifetime. So you might do a life chart or timeline where age is along the bottom and mood high or low. So this isn't particularly necessarily for Leanne, this is just a fictionalized one for somebody else, but you can see that the episodes are here of high and low, and there are also life events on here, positive and negative life events, and period of using medication. And you can use this to think about what sort of triggers and situations make me particularly vulnerable, but also what helps me to stay well. And that can also be helpful in terms of thinking about how do I want as much control as I do have over my life, how can I use that to live my life, but maybe reduce unnecessary triggers. So the other area that these protocols tend to focus on, I said, was depression, so bipolar depression. Here, the CBT protocol draws largely on the one for unipolar depression, so mainly the Beckian one. Aaron Beck. From a long time ago, many decades ago. And this basically says that people have kind of beliefs about the self, the world, and others that are developed based on early experiences and later experiences. And these are sort of dormant until activated by a trigger event. And when they're activated, they shape the way that we see the world. So they influence our information processing, so our reasoning, our attention, and our memory. And that gives rise to particular thoughts. So if we have a load of beliefs about ourselves, the world, and others that are quite negative, when they come to the fore, when they're activated, maybe because something bad happens, we start attending to negative information, reasoning more negatively, and remembering negative material. And we're more likely then to have negative thoughts like they don't like me, I'm boring, or whatever. And then there's an interplay between what we think, how we feel, what we do, and how our body is. So if we're thinking they don't like me, we might feel sad, ashamed. We might be more likely to avoid that person or social contact, and we might feel a kind of heaviness in our body. And Newman and colleagues suggested that this could be bidirectional. So as well as having the beliefs having an extreme negative side, they might also have a kind of super positive flip side. So if you had a belief like underlying belief like I'm a failure, the flip side is I'm an incredible success. And depending on what's happened, one or other set of beliefs might get activated. And if the hyperpositive beliefs are activated, then you're attending to the very positive information in the environment, you're remembering good things, and you're reasoning in a positive direction. So you might have positive automatic thoughts like, I can do anything. And that then affects how you feel and what you do. So it can go either direction depending on which beliefs are activated at a given time. Now, I don't have time to go into the evidence base for all of this. Actually, the extension of this to high mood, there is some evidence to support it, but there's also some trickinesses with it as well. There are other kind of theories out there that say a similar-ish thing but slightly different, but I don't have time to go into that here. But just to illustrate what this could look like for Leanne, so in terms of mania, at X's death, she's trying to distract herself by doing lots. So she finds that she's very busy and productive, activating beliefs like I'm super powerful. The more I do, the stronger I become. If I slow down, I'll go under. Having thoughts like I can make anything happen, feeling energetic, excited and confident, going out and meeting new people and moving towards a high. Later on, she's exhausted after mania. There's work and financial problems. That activates beliefs, the opposite beliefs. I'm weak and pathetic. If my life is a mess, it means I'm a mess. Thoughts like I can't cope, feeling miserable and anxious, withdrawing friends and avoiding friends and work, feeling tired and more likely to go low. So this is just a whistle-stop tour here of giving an example of what we might do in therapy. So in terms of what we might do based on that understanding, a big part is looking at routine and patterns of behaviour. So this goes beyond just sleep patterns, but looking at how can people implement what is a manageable routine that helps people come out of depression, but also to stay well. So balancing kind of different types of activities across the week, not cramming it full of exciting things, but also not avoiding excitement. And so life is a bit too calm and boring. We often look at calmness, connection, joy and achievement, and then a lot of problem solving around barriers to actually getting those sort of things into your week. And then because it's CBT, we also look at cognitions. So we might help people work, first of all, with noticing these thoughts when they come in and looking at alternatives. So using standard techniques that we'd use with unipolar depression around negative thoughts. When it comes to the high thoughts, we're not trying to prove to people, you've got this thought like I can cope with anything. Actually, you can't cope with anything. You can cope with nothing. We're not trying to prove the opposite, but we might look at how useful is this thought? How much would it help you if you followed it completely, and kind of take a step back and evaluate the situation. And you may do some work around some of the underlying beliefs as well. So a little word about involving family or friends. Some of the psychological therapies are family or system based in nature, so focused family intervention. For the individual ones like CBT, we tend to encourage people to involve trusted others if they'd like to, and that can be in various ways. It can be just sharing important ideas and materials. It can be them asking, for example, their partner to help them with certain tasks like monitoring their mood. And it can be also inviting people to key sessions to act as a supporter with the therapy. So, final thing, people often ask, well, who should be offered what, when? There's very little evidence or guidance on how we might sequence these different psychological interventions, quite aside from medication. So NICE, the only thing NICE says about this is that family intervention should be offered to those in contact with families, in terms of who gets what. My view is, I think it's important to consider the person's goals and presenting issues. Don't just assume because they've got a bipolar diagnosis, they need to launch into relapse prevention work. So are they feeling well and looking to reduce the chance of relapse, in which case you might do relapse prevention protocol? Do they have current depression, in which case you might follow a depression protocol? Is it more about that they want to work on relationships, in which case you're drawing from stuff that I haven't covered here? And similarly, if they're presenting with another mental health difficulty in the context of bipolar, like PTSD, so you might work with the bipolar enough so that the person feels ready to work on that difficulty, but then primarily focus on the anxiety disorder or the PTSD, for example. Okay, so that was a real whistle-stop tour there. What I'd like to do now is just invite you to have a little think about this. I will see if we can put you into groups for a couple of minutes, just because we're kind of coming towards the end. And based on what you've heard today and what you already know, I'd like you to think about what ideal care would look like for someone with someone like Leanne. So remembering Leanne, the description of Leanne's situation, what would it be great if we could offer her as health services? And then you might think about how close is your locality to being able to offer this? And is there anything that could help bridge that gap? So I'm going to stop sharing.
Okay, so Bipolar UK is a national charity supporting all aspects of bipolar. There are over 50 support groups around the country that are affiliated to Bipolar UK. Some offering face-to-face meetings, others peer support, online or telephone support. I help to run the Torbay Bipolar Group, which offers weekly face-to-face meetings every Tuesday morning and a monthly evening meeting on the first Thursday of each month. So our group has been running for just over 30 years now. I think we've got around about 200 members on our database, and we have between 15 and 20 people attending our Tuesday sessions now. We provide peer support and shared knowledge and experience of bipolar, along with mindfulness, art therapy, and music. We also run some outdoor sort of activities, one of which now is outdoor Tai Chi. It's a Tai Chi class which we have, or we offer to everybody every Thursday afternoon down at a local beach in Paynton. We've also linked up with DSA, which is a Torbay sailing charity. So anybody that's keen on just getting out on the water, keen on blue spaces, are able to sail with this charity, basically, free of charge. We're also on the waiting list for an allotment at the moment, as a few of our members thought it'd be quite a good thing to, to do as a sort of community. So we're just waiting to hear about whether or not we can get one. For the Thursday evening meetings, we try and invite in guest speakers whenever we can. For example, Chris Sullivan, who's the Deputy Chief Pharmacist for DPT, he comes in once a year. Stephanie Romanescu, I'm not sure if I've pronounced that right. Anyway, she's a lead sleep psychologist for the Sleepyhead Clinic in Exeter. And she's just, I don't know if you can see this book I'm holding up. Anyway, she's just recently written this book all about sleep, which we're all finding quite interesting. Kim Wright from Exeter University comes along once a year to report on the different bipolar studies going on at the university, and we've got Dr. Tom Cant, who's a local psychiatrist here, who's been leading the Open Dialogue programme in Torbay. It's been piloting, and he's coming in a couple of weeks just to report on that. Finally, 3 of our facilitators are now employed part-time by the DPT as peer support workers, and sharing their lived experience and with the different mental health teams in the area. And this is helping to forge better links between the voluntary sector and the NHS mental health services. And before I finish, I'll just quickly comment on the bipolar mood scale, which hopefully you can all see. I think anybody with bipolar can identify with this mood scale indicator. I know when I saw it for the first time, it put a lot of things into context, and it helped me sort of define and identify just about all the different mood states I've experienced with my bipolar. It's a useful tracking tool when you are monitoring your mood, and I think the True Colours mood monitoring program, which unfortunately has stopped now, but I think that was based around the red, amber, and green colouring on the mood scale. I think it really is a useful tool just to monitor mood, and for people that do kind of sign into this and do it on a daily basis, by recording their scores, I think this can sometimes help healthcare professionals with their bipolar. And then finally, just to finish, I don't know if any of you have seen the recent kind of documentary that Heston Blumenthal put out. I think it came out a couple of months ago, called My Life with Bipolar, and I found it a really, really honest and quite brutal account, really, of his bipolar, and would recommend, if you can see that on iPlayer, it's well worth watching, and that kind of ties it all up for me. So thanks for listening.
Oh, thank you so much, Pete.